platform, PMD Alliance gang. It's just been a pleasure. And we've had some really amazing momentum building here with some activism and advocacy around various issues with Parkinson's. And it's with great pleasure that I continue some of that dialogue. So wanted to introduce Dr. Nabila Dahodwala, who joins us from the University of Pennsylvania. You've met some of her colleagues. We had Dr. Stern come on and a few others from the East Coast. And Nabila has, she was a fellow and worked at the PADRIC, which is one of the Parkinson Centers of Excellence across the country. And I run the one here on this coast in Los Angeles, and Nabila works at the University of Pennsylvania, where they host the other PADRIC that's our main, one of six that's really the center of much of the coordination of this. And I think during her work, she really got interested in some of the disparities in healthcare and started to do some research. In fact, I watched a video that she recorded 10 years ago about the lack of information in some of the areas of healthcare disparities, including race issues and some gender issues. And we'll find out if we've come a far way. I would guess that we probably haven't come that far in 10 years in terms of the unmet needs and learning more about this. But Nabila will teach us a little bit about this through some slides. But first, I wanted to get to know you a little bit, Nabila. Tell us a little bit about your journey to becoming a doctor, a neurologist, a movement disorder specialist, and then maybe how you got interested in this area.
Sure. Yeah. Wow. Well, it has been a long journey. I guess I am the child of immigrants. My parents are from India, and my mom is a physician. And I think she had a really large role in me becoming a doctor. I think I really looked up to her growing up. She was a working mom with 3 children, and she kind of balanced everything as like a super mom. And I always really enjoyed the sciences and helping people. So that's what led me to medicine. I think neurology was largely because of my teachers in medical school. I went to Columbia, and the neuroscientists there are just amazing. And they really made the brain come to life and just made it so fascinating for me. And then movement disorders was similarly because of personal experiences. In my last year of medical school, I spent a month working in Venezuela with Nancy Wexler, who ran this very large Huntington's disease research program there, largely because there's a family history of Huntington's disease in her mother, and she was at risk, and she has just disclosed that she also has it. But she just was so inspiring, and working with patients with movement disorders was really it just had, for me, a lot of meaning that I would potentially be able to help manage their disease, but there was still a lot more for me to learn, for us to learn, for research, for all of you to be able to help discover better treatments. And I liked that balance of the relationships with patients, but still trying to find better therapies. So here I am. I think the health disparities came in I've always had an interest in working with vulnerable populations, underserved populations, and in social justice, and really trying to, I feel like healthcare disparities really brought together all my interests in science and neurology and social justice. And there's a lot that, again, we need to change in our systems of care and in our personal interactions to help defeat inequities in care, really.
Absolutely. Well, and I think that this time with COVID-19 and just the climate right now, political climate in the United States, but also all over the world, has given us pause to reflect a little bit about, the systems in which we all live and what we take for granted, and, what this virus is teaching us about, uncovering a lot of the social injustice that we have in this country. On this series, we've kind of expanded to including people all over the world, and we've had some topics, as I told you about, and I know you watched Dr. Kilbane's talk last week on global issues in Parkinson's. And it's been just a really eye-opening experience for me to learn about this and have some strong female and diverse voices on this show, which has just been a real source of pride for me. So welcome. And I know that you had prepared some slides, and maybe we can start there, and then we'll sort of get some of these questions going as well. And just before, because I don't want to forget, Nabila was a participant in a beautiful program by the Davis Phinney Foundation that we can link at the end of this, that had David Leventhal was the moderator, and a number of people from many cultures, people who are working with African-American populations, Hispanic and Latinx populations, all kinds of populations. So definitely want to have people look at that video. I thought it was really enlightening and a nice panel discussion. So we'll link that at the end of this as well. So yeah, go ahead and teach us a little bit from your slides, and we can start there.
Let me share my screen. Okay, so thank you for the introduction. That you guys know what I'm going to talk about. It sounds like through this series you've been already discussing healthcare disparities, and that you had a talk on global issues around Parkinson's disease. So just to get a little bit on the same page again, I wanted to be clear about some of the definitions, and sometimes I'm not clear, so I'm going to do my best to be clear. Is we often use the word disparities to include differences and inequities at the same time. And I think it's probably better to try and separate those two out. So differences are exactly the way we think about it from a scientific perspective. So any difference in incidence or risk of disease, prevalence, or how frequently we see a disease, morbidity or death, morbidity, or which is the same as disability, and mortality or death of a disease. And there may be differences between groups of people that we see. So we may see differences between men and women. We may see differences based on where people live. And some of it may be, and the underlying reason for those differences isn't yet clear. We're just saying that we see differences in these rates of disease, or these disease measures that we have. Whereas inequities are really differences in the quality of healthcare or treatment that are not due to clinical needs, preferences, or appropriateness of intervention. So these are differences in care that should not exist, and we already know that they should not exist. And that can be hard to tell apart. Sometimes we don't know why we see differences in care, and getting kind of digging down deeper to understand why they're there will really help us develop to change the way we deliver care and reduce these differences or disparities. So I kind of jumped ahead, but why should we care about racial differences in care? And most of my talk, I'm going to focus on race and the social construct of race, the way we think about it, and not sex or gender or other group differences. Although there are differences by sex and geography and other groups, that is true in Parkinson's disease, but for today I'm going to focus mostly on race. So if we can understand why we see racial differences in Parkinson's disease, it'll ultimately improve care for everyone, because it will help us understand the underlying physiology of disease and help develop more personalized treatment. We all probably see how different Parkinson's disease is between people. So the larger understanding that we have across people from different backgrounds and that look different will help us understand what's happening with Parkinson's disease. Also, when we have variability in the care that we provide that's not due to biological factors, it usually means there's a problem in the quality of care that we're delivering. And if we reduce disparities, that we ultimately end up improving quality of care for everyone. And lastly is one of the reasons that has been really close to my heart is this idea of social justice and reducing inequities in our society and communities. So when we talk about race, and I mentioned earlier that race is really more of a social construct more than a biological construct. There isn't like some, like the genetic variability that we have between us as humans is greater within races than between races. So it's not like there are distinct genetic profiles that like would identify someone as Black or white. So we are all very diverse within our genetics, and that's really what is one of the biggest things that contribute to disease risk, although there's also the environment that we interact with. So there's some interaction between genes and environment. And part of that environment, I think that's really important when we think about race, is that race is often very highly correlated with other indicators of socioeconomic status like education, wealth, and occupation. And all of those socioeconomic status indicators also impact your health. So when you have less wealth, you have poorer health outcomes for a variety of reasons. But if you are also Black and have you're more likely to have low wealth. I don't want to discount what's unique to just skin color, though, which is that people who have brown and Black skin are more likely to face discrimination and unconscious biases, to face institutional racism like residential segregation, and ultimately have higher exposures to environmental stressors that can change disease risk. But a lot of the biases and racism we see, and what I'm going to focus my slides on today, are differences in treatment. So not necessarily disease risk, but once you have Parkinson's disease, that people from different groups are treated differently. Oh, I'm stuck. Sorry. Oh. So let's start with missed and delayed diagnosis of Parkinson's disease. And I think this is where someone starts. So if someone has symptoms of Parkinson's disease, before they can get treatment, they have to get diagnosed with Parkinson's disease. But in fact, there are many people who are undiagnosed. And I think in the global Parkinson's disease talk, this was brought up globally, that a high proportion of, I believe it was Africans, but really this is true across the globe. There are people who have Parkinson's disease but haven't been diagnosed with it, so they're undiagnosed. And in the one study that was done in the United States, where we actually went door to door and assessed for Parkinson's disease, about 40% of the cases that they found had been previously undiagnosed. So they didn't know they had Parkinson's disease. And of the cases that were undiagnosed, they were twice as likely to be Black than white. And so you start to get this picture that Blacks may have Parkinson's disease, but are not even getting identified with Parkinson's disease. So that's one of the first steps for understanding inequities. If you're not getting diagnosed, you're not going to get treated. And I just have a little bit more data showing that this same idea, that in another study that I was a part of, we showed that when Blacks do come in for care, they're coming in at later stages. So that again suggests that not only are people getting missed, but when they ultimately do come in for care, there's delays in their care. And similarly, a study in Baltimore showed the same thing, that when Blacks come in for care at a specialty center, they already have worse motor scores and greater disability. So I tried to dig a little bit deeper to understand, why do we have this delay? And one hypothesis I had was that Parkinson's disease can be kind of hard to diagnose. We don't have a blood test for this, or like a simple exam maneuver we can do in the clinic. We can't put a blood pressure cuff on and tell you have high blood pressure. So it really requires like a mix of a patient talking about their symptoms and reporting what's bothering them, and the physician or healthcare provider doing an examination and then putting this all together and coming up with a diagnosis. And so I had a hypothesis that maybe there was a disconnect, that maybe the disability that people were reporting was, that maybe it wasn't always as severe as what clinicians were observing, or maybe it was the reverse, that they were not reporting a lot of disability and the physician was seeing a lot more disability on exam. And if there was a disconnect, then there might be underreporting of symptoms. That is, that some people might not report very much disability, which might mean they don't come into care as soon as someone else who reports more disability, despite having just as severe symptoms on a more of an objective measure. So I tried to compare these two, comparing what a patient reported for disability and what the physician observed on the examination. And when I plot that out, here, this axis is what patients reported as their disability, and here is what the physician found. And I compared the two, and the blue circles are the white patients and the red triangles are the black patients. And you can see here that this red line falls under the blue line. So for the same level of physical exam findings from the doctor, let's say here like 30, a black patient reported less disability than a white patient. So they were underreporting their symptoms relative to the white patients. And when you account for this difference in reporting of disability, that actually accounts for some of the delays in their diagnosis. So that was one idea that I had that might explain delays in diagnosis. And I tried to follow that up with another study looking at health literacy, because I think part of understanding your symptoms and knowing to go to a doctor or to complain about your symptoms is to know what might be related to Parkinson's disease versus normal aging, or being able to distinguish your symptoms is, I think, very challenging. And not only do people in the community have a hard time with it, but many doctors have a hard time with it, many primary care doctors. And so I just wanted to get a sense of what the overall knowledge about Parkinson's disease was in the community. And I'll just skip ahead because it was, in fact, here are all the answers between different communities. So African Americans, Chinese Americans, and whites, and they're all actually very similar. And not surprisingly, I don't think the knowledge about Parkinson's disease in the general community would be super high. We compared it to the proportion to a support group member. So someone already diagnosed with Parkinson's disease participating in support groups, so fairly knowledgeable. And across all the questions, the support group members knew more. But the overall finding was that the general knowledge about Parkinson's disease in the community is relatively low. And there were maybe a few differences by race when we discussed in a more qualitative session what were some of the barriers to going to care, where African Americans or Blacks were more likely to bring up issues around insurance and trust and religions, whereas the Asian Americans that were predominantly Chinese immigrant population living in the Chinatown area of Philadelphia mentioned language as a major barrier, and whites mentioned not being aware that they had it, so having insight into your symptoms. But I think this overall led me to think about how can we change this? And I don't know if, I think patient education and community education about health is a really important thing, but I also think that that's probably not the main focus that we should be putting our energy on, because it really requires like educating all people, where maybe we can focus it more on physicians and healthcare systems, which is where we really need to be providing the safety net for older adults and older adults as they're developing disability, so that like to expect an older adult to know every possible disease that they might be having is, I think, a very high bar. But I think physicians and healthcare systems should play a large role here. So when we think about physicians and healthcare systems, they are also contributing to the inequities that we see in care. So a major thing is geographic disparities. Movement disorder specialists tend to practice in large and urban centers, but that's not where everyone lives. And so when you combine the impaired mobility and cognition from Parkinson's disease, it makes it even more burdensome to travel to see specialists. There have been some efforts to try and improve access to neurologists in the US, and this is nowhere near as bad as the access problem that we see globally. Like the number of neurologists per the 100,000 in Africa was much worse than this, but just looking at within our Medicare population, so people over the age of 65, this graph shows what proportion of people with Parkinson's disease who've been given the diagnosis have access to a neurologist, and how many people are actually seeing a neurologist. So here, the dark red, between 77 and 100% of these patients with Parkinson's do not have access to a neurologist, and they're not receiving care from a neurologist. So that's a reasonable amount of the middle of our country. And then there's a gradation. So there are very few areas where everyone is seeing a neurologist. There's still, I would say on average, about half of people with Parkinson's disease see a neurologist, not even a movement disorder specialist, but a neurologist. And then the other half are seeing their primary care physicians to manage it. So what Ray Dorsey did was he tried to improve access to movement disorder specialists, and he tried to overcome this geographic and distance barrier through a randomized trial of telehealth. And now you all may be very familiar with telehealth because of COVID, but this was prior to COVID. And he had a group of people that received virtual house calls through the telehealth and a group of people that got their standard of care, and then compared how people did between the two groups. And there was no difference in the quality of care or quality of life that people experienced. There was no improvement in the telehealth group, but I think that was okay. There was also no worsening. But on what was more important was that 98% of the people who received the telehealth felt that it was, 98% of the people that were randomized to receive telehealth did receive it. So it showed that it was feasible, and most people saved time and the distance that they were traveling. So it was convenient. But what I want to focus on is that of this people that he studied, 73% were already seeing a specialist and 74% had a college education. So it wasn't really getting at the people that we're worried about. It wasn't getting at the people who are seeing their primary care doctors for their Parkinson's disease. Also, another major thing that we've seen more highlighted now with COVID is that in this sample, 96% used internet and email and had broadband access, but just for some context, older adults who earn less than $30,000 a year, only 39% use their internet and email, and only 25% have broadband connection. So there is this still digital divide that doesn't necessarily mean that telehealth will be the answer to improving access. I think there's still ways to go to improve internet connection and broadband access so that people can access a lot of these resources that are through the internet. Physician accuracy, some of you may have experienced this already, is not 100% accurate in Parkinson's disease. And when you have this difficulty in the diagnosis and uncertainty, it leads to variable detection. And that's, I think, a major obstacle that leads to inequities. So if you are a provider that is accustomed to seeing a white male with Parkinson's disease, you might not think about that when you see a Black woman with a tremor. And because we don't have like one test for Parkinson's disease, it leads to these implicit biases that play a role in detection of disease. And it's normal. I mean, I don't want to say that all doctors do this, because we have to have these cognitive shortcuts that we use when we're approaching a patient. We think about their age and what their likelihood of having Parkinson's disease is. And unconsciously, their sex probably plays a role, and their skin color might play a role. And the more we learn about these implicit biases that aren't based in biology and that we shouldn't be using, we'll be able to unpack them and not rely on the heuristics and shortcuts that we do. So, okay, the last thing on the diagnostic side is the referral to neurologists. So I mentioned this on the earlier slides, but most people aren't seeing a neurologist, but when you have Medicaid, you're even less likely to see a neurologist, and Medicaid is the insurance for people under 65 that qualify because of income. So they don't have it either through their job or make enough money to buy private insurance. And similarly, in the Medicare population, African Americans are less likely to be seen by a neurologist than whites with Parkinson's disease. So that leads us to treatment. So we already know that Blacks have missed diagnoses, delays in diagnoses, are less likely to see a neurologist. But now on top of that, even once they have received a diagnosis of Parkinson's disease, they're less likely to receive high quality of care, the same medications and physical therapy, deep brain stimulation surgery, or participate in clinical trials. And the next few slides goes through the data, and I'll try not to spend a ton of time on the studies, but I just want to highlight how, what the amount of inequities there are in the care, because they're really quite striking. So quality of care, this was actually done where Dr. Subramanian works with at the UCLA VA, the PADREC. Dr. Cheng had created a set of quality measures for Parkinson's disease, and then he went back and looked through the charts at the VA and compared how many of the patients who were white and non-white were receiving this high quality of care. And the whites with Parkinson's disease, and they're all getting treated, you know, similarly in the same setting, but whites with Parkinson's disease were less likely to receive this high quality care. It was largely due to differences in receiving treatment for depression. Sorry, my thing keeps going away. I did a study also using Medicaid patients and looked at a group of new patients who were newly diagnosed with Parkinson's disease, and then followed them for the next 6 months to see what treatments people were put on. And here are some of the data. So the gray bar here are the white patients with Parkinson's, and the yellow bar are the Black patients with Parkinson's disease. And about somewhere almost 40% of the white patients received treatment for Parkinson's disease after their diagnosis, but only about 12% of the Black patients did. So they were 75% less likely to receive any treatment, and that included physical therapy or medication. If you just look at the medication findings, it's the same pattern. On the other hand, both groups were seeing their physician just as much, so it wasn't related to not seeing their physician. It was really an issue of getting treatment. In surgery, we see the same disparities. In fact, I think they might be magnified here. So in this one study that reviewed hospital discharges for people that received surgery for Parkinson's disease, so there were a total of over 1,700 patients, only 9 were Black. So less than 1% of the patients were Black who received surgery for the Parkinson's disease. And this was published, I want to say, in 2003, but these results have been replicated again in more recent times. These numbers haven't really changed dramatically. Clinical trial enrollment, we see the same really dramatic inequities in care. So this paper reviewed 32 published clinical trials in Parkinson's disease. And of those studies, only 9 even showed the race ethnic composition of the people who participated in the study. And of those 9 studies, sorry, I'm moving my thing. There's a total of almost 7,500 subjects, only 65 were Black. So again, less than 1% of people participating in clinical trials are Black. We see similar disparities or inequities in outcomes of care. So African Americans with Parkinson's are less likely to see a neurologist, and that translates to being more likely to be placed in long-term care or skilled nursing facility. They're more likely to have a hip fracture than whites with Parkinson's disease, and they have a higher mortality than whites with Parkinson's disease. So what can we do? So in researching the inequities and disparities in care, the first step is detecting disparities, which have showed you that they exist. The second step is understanding them. And we're starting to get at that a little bit. There maybe health literacy is playing a role, and then ultimately we want to reduce them. So I've shown you that compared to whites, Blacks have delayed diagnoses and are less likely to receive high quality care, medications or surgery, and participate in research. Perhaps health literacy and Parkinson's literacy plays a role in some of the delays to diagnosis, but there's also these provider and clinical encounter factors that play a role, the uncertainty in diagnosis. There also aren't standard protocols for what treatment you should be on, so that may lead to variability in how treatment and medications are applied. The issue in trust in the clinical encounter and language barriers play a role, and then ultimately the access to neurologists. So we have lots of barriers in place before someone can see a specialist. So what can we do? Obviously, education programs I mentioned before, I think they have value, but I don't think they're ultimately the answer. Community health workers, I think, is a really promising strategy where a member of the community kind of acts as a bridge between patients and the healthcare system. And they can speak the language of the healthcare system and help patients navigate the complexities of the healthcare system, but also understand what the social setting and the non-health factors that are contributing to a patient not being able to get the care they need that we often as providers don't always understand. I think cultural competency training is very important, and that should be happening at all stages of training for providers. There can be, I think, policy changes that I'll go through in a later slide. And telehealth, I'm not giving up on. I do think it is a very powerful tool to improve access to care. I just think we have to think carefully about how to apply it so that everyone can use it. There have been some successful programs to reduce inequities in care, and they often involve multidisciplinary care teams, cultural tailoring, patient navigation, which I mentioned, this interactive skill-based training, and I think this is really important, collaborating with non-health partners. So we often, as providers working in a hospital or clinic-based system, really focus on the medical side of things, but ignore how much the social issues also impact healthcare, and they really need to come together. And I think we should be doing a better job collaborating with these non-health partners to improve care. And this would, improve care for everyone, but particularly underserved minorities. So what are some of the next steps for Parkinson's disease? I think it's very important that we increase enrollment of underrepresented groups in Parkinson's research. If we're really going to move towards a personalized medicine approach to care, if we don't have more diversity in our research, we're not going to understand what the differences are, what are some of the biomarkers that are important in observing progression, and what are the best treatments. I think we have to also think a lot about how to improve adoption and adherence of Parkinson's therapy among vulnerable populations. And education and empowering people is very important. I think not just about Parkinson's disease, but about general health and digital health, literacy, computer, and technology. So I mentioned this a little bit. There was this great article in JAMA Neurology, just JAMA in 2017 that really laid out what are some of the steps, both in terms of the infrastructure and things that we need to do to change the current system. I mean, we've been aware of healthcare disparities in health for decades, and very little has changed. And so I think we really have to fundamentally change how we deliver care. And one is paying for value. So right now we are incentivized for volume, for seeing more patients, but we should really be incentivized for improving outcomes. And part of that should include integrating the social and medical services, not keeping things so separate. I mentioned empowering people. I think this is a really important piece. That can include improving health literacy, improving access to telehealth, making digital broadband connections cheaper or free. As we've all been moving to virtual schools, I've thought a lot about this, and my husband works for Comcast, which is a huge internet provider in the Philadelphia area, at least. And I said, we've had these discussions about, shouldn't internet just be free for everyone? And now that so much is reliant on internet connection, like school and health, shouldn't it just be at least free for people who can't afford it, kind of like we have Medicaid? And then we have to really think about how we can personalize the care that we're delivering to the context of the person we're treating. Instead of expecting people to come to us and adapt to the way we deliver care, we have to think about how we can change how we provide care based on the context that the patient is in. I think we have to activate communities. This has been a big thing that's come up with the COVID-19 pandemic, is that we really don't have a very good public health infrastructure. And if we can invest in the local public health systems, I think that'll improve the health of everyone, including people with Parkinson's disease. And think about working within the community for community-based health strategies. From an infrastructure standpoint, I think I mentioned the cultural competency training, which is very important, and the science. I really, there is more to do on the research front that is really patient-oriented, that we can do to understand why we see these inequities in care. So that is all I have for slides, and thank you. It was a little bit, there's a lot of probably data in there, but feel free to ask me any questions.
Yeah, no, that was great. So maybe we'll just stop sharing, Nabila, so we can see your lovely face there. Thank you. That was a great summary. I mean, I think it brings up a lot of unmet needs and issues, and it's sort of like going down this rabbit hole, and then you sort of feel sometimes like, where do we even start, with, is there low-hanging fruit? Is there easy sort of solutions for any of this? And is it, I think you've been at this research for 10 years. One of the questions that's been posed here is, you started this research 10 years ago. Do you have a sense that the needle is moving and the inequities and disparities are improving? What's your sense of the trajectory, just sort of as an opening question?
I think, this is tough. I would say that the recent social injustice that we've seen around George Floyd and Breonna, around the police violence, I think that has kind of energized everyone a little bit more. I think for a long time, I felt like I was the only person shouting really loudly from the top of the mountain, and everyone's like, well, it's just a really hard problem and there's nothing we can do about it. But it's great that you're doing it, and let us know when you figure it out. But I think that to really change it, it does require a lot of resources and people who are all committed to it. It can't just be one person. Not that I was the only person doing it, but it does require like changes in the whole system, the way we approach care. Many things are universal. They're not even unique to Parkinson's disease. And so I think, I think it's starting to move now. I'm very excited to see where it goes now that so many more people are working on this and interested in this. And I think they realize what a problem it is. But I would say in the past 10 years, there have been small changes. I wouldn't say it's been a remarkable change. I think now is the time. Now when there's a lot of momentum, we have to take advantage of it and really try and change the underlying systematic racism that exists, that things that are interwoven in everything we do. We don't even realize it.
Absolutely. I agree. I think that there is a momentum. I think there is a spotlight and that we have to seize the day and work with, I think just the causes that are out there right now, including, the COVID, time frame is sort of shining lights on disparities. And we, I think as neurologists and Parkinson's doctors need to figure out what we can do in our own, backyards and communities, and sort of figure this out together. I went to medical school in Toronto, in Canada, and it was a while ago, about 25 years ago, I went to medical school. And we spent so little time really talking about the social determinants of health. And I've been a Parkinson's doc for about 20 years and really have been doing a deeper dive into things outside of, standard Western medicine, going to integrative medicine conferences, and have just been really, my eyes have been opened at these conferences, just talking about things like, the fact that where the zip code in which you're born really has a lot to do with what your outcome is health-wise. Global warming has, something to do with it. How close you live to freeways can affect, your health, air quality, all these things that we really spend very little time learning about. Even basic things like diet, exercise, as determinants, social connection, which I've spent a lot of time and energy thinking about recently. And these things were really not emphasized. I feel like we spent a lot more time talking about the Krebs cycle and, the science formulas and chemical structures. And really, I didn't learn about any of these things. Maybe I was sleeping in the back. I don't really know where I was in these lectures, but I find these to be so important. And I think hopefully, we can restructure even medical school, learning, and even from, educational systems for children, learning about what really makes a difference. If you eat right and exercise and are nice to people and try to make friends and, these sorts of things, and take care of, the older people in your society, that, hopefully we can all live in a better place. I think we've had very little emphasis on this, but a lot of your, data is really interesting. There's a couple of questions. One was about, is the study by PAN, when they talk about white populations, because I didn't see Hispanic or Latinx broken out there. Do you know where that was done?
Yeah, we didn't. No, yeah, she was my mentee. She was a public health student at Drexel, and she was a native Chinese speaker. So we ran focus groups in senior centers that were in largely homogenous, like segregated neighborhoods. So there were several that were in areas of Philadelphia that were predominantly Black, that were predominantly white, and then predominantly Chinese speaking, but we did not go to Latinx communities for that study.
Okay. I'm also intrigued by this. Kathy asked, why did the Black patients not get care after diagnosis? And when we talk about who got on pills, were they offered medicine and they didn't take it? Or they didn't stay on it? What was the glitch there, or were they not offered it in the first place?
So the data that we had was from insurance claims. So all we can see is that there were no claims for the medicine. So we don't know if they were offered it and didn't take it, or if they were never offered it. Okay. But my suspicion is that it's probably a combination of both. But probably more like based on other diseases, we see that the interaction when you have a Black patient and a white doctor is very different than when you have a white patient and a white doctor. So like there have been studies that are very cool where those clinical encounters have actually been audio taped, and then someone else has listened to them. And it turns out when you have a white patient and a white doctor, there's about like equal amount of conversation. But when there's a Black patient and the white doctor speaks a lot more than the patient does. And so if you're in a setting where you already don't feel like you have a lot of power, and then you don't feel like you have a voice, and you're not really able to communicate what's going on, and maybe the provider gives you a prescription, or maybe you don't, but you don't have a chance to ask questions, or you never were able to go through what the side effects are, you might not feel comfortable taking the medicine. So I think my sense is that and then providers might also feel like, oh, the last 5 patients I said, they weren't adherent to their medicine, they didn't follow through, so they feel less inclined to offer the therapy. But I don't know. I don't know in Parkinson's disease where the obstacle is. There is that the PSG study that did look at treatment amongst minorities. And there was really, the efficacy is the same. Like we know that the drugs work in Blacks and Asians and Latinx communities. So we should be using them just as often.
Yeah. There's been a question about the community healthcare worker situation. It is something that I heard a lot about in the Davis Finney talk too. Where are these people? Who are they? What is their training and who pays for them? Could you tell us a little bit about that?
So it depends on the community you live in. I think in Philly, we have a group of community health networkers that are linked to Penn, and they are partly paid for through, I think, grants, partly paid through by the university because it ends up saving money overall, like the health system. It prevents hospitalizations, it ultimately reduces costs of care. But it was very much like, it's not like a national policy that we have. Like every community kind of figures out how it can work within their own community. And it really took like a local champion to get the program started and build it up. It's not like you can ask your hospital for some money to like start up a community health care workers program and they're gonna be like, sure, here you go. Like you kind of have to, you really have to advocate for that. And then, I mean, the evidence for it is very strong. So I don't know, I mean, depending on, you know, how progressive the leadership is, they may understand the value of it because it really does save costs and improve outcomes. So I don't think you have to argue very much, but it might not be a priority for health systems that really, like the health systems currently are built for white people. They're built for, I mean, health systems, at least where we live, make lots of money and they are happy with that. They don't want to change the system. They don't have an incentive to reduce inequities and treat people from lower socioeconomic status. So there really needs to be more of a push for social justice. And I personally think it needs to come from more of a public good government perspective. Like, I don't think if you're working at a for-profit institution, they're gonna prioritize this.
Yeah, there's a fundamental problem with the way that reimbursement in the health system is sort of based, I think, and funded and paid for, at least in this country, but even in other parts of the world. In Canada, there was community healthcare workers in Toronto, and they were actually part of many communities. They were actually from certain communities, embedded in those communities, and could actually help people and you know, sometimes could translate things and help, you know, us get the word out. And even in there's a lot of refugee communities and stuff, we're able to really, you know, target those populations quite beautifully. But again, you know, it's a large metropolitan center with a different sort of healthcare payer system. So you said a few things that really struck me. One, I really like the data that you showed, and we should really emphasize that to people around you know, older populations who have access to internet and who can actually afford and get it. You know, that's a striking, you know, information point that a lot of the patients that are in the Parkinson's sort of age groups really are not going to be able to get internet. And so I do think that those sorts of populations, if we're really going to have a push for telehealth, need to get these access to, you know, broadband connections and education around using technology. That was really interesting. Another thing that you brought up was the implicit bias. And I think people have been talking a lot on Twitter and stuff about the sort of, you know, the image of the Parkinson's patient as this sort of bent over, elderly, you know, white male. And that sort of unfortunate, you know, picture is what a lot of doctors who might, the only idea of that, what they think of of Parkinson's patients is what they might have learned in one lecture in medical school, the one patient they might have met or seen somewhere on the street. And that is what they think should be, you know, in front of them if they're really going to make this diagnosis. And I think we really have to dispel that myth. So I think that some of the very low-hanging fruit is just, you know, basic education that, you know, this is not a disease of white old men. This can happen to any age population anywhere in the globe, in every community, because I think that basic education, and like you said, I mean, many of these people, it's not that, you know, telehealth is not going to dispel, is not going to change the access issues for who's going to be able to access neurologists. I think it's really still going to be that a lot of people are only going to be able to get care from primary care doctors. And if those, or providers, right? Some of these are whoever, nurse practitioners, physicians assistants, nurses sometimes. We need to teach them about what a Parkinson's patient could look like, and how to target, how to treat and get those people care, because I think that is a huge part of the problem. So a few other things. So the issue with patient navigation, do you have a sense of how to help with that? I mean, I think so. I guess it's sort of maybe education, and then helping that patient understand sort of where the barrier. Do you have a sense of how to navigate that at all, sort of from the system? Because it seems like that's a lot of the issue is, some of these populations don't know where to access care. I'm not too sure, because it does seem like it comes up a lot on sort of these slide sets and things, is the value and navigation piece.
Yeah, I think I think it's easy when they're already in your care. So our center has a social worker and we have a nurse navigator, and we can help once you're have already stepped into our door. But I think the hard thing is how do you get, or you might not want to come to our center. You might not want to come to a big academic center, and you like your local doctor and you trust him and you have a good relationship, and why would they not be doing the right thing for you? So I think what we have to do as specialists is move out of our home and move into the community more. I think that will help, and bring our resources with us, bring our nurses and social workers, and help once we are more in the community and connected and providing care in the context of where the patient lives. I think it'll be easier to navigate that. I think, and we're used to where we are, and we're a little bit less mobile, but I think we can do it. I don't know if you guys know, Jory Fleischer has done some really cool work on home visits, and she had this, I never heard this term before, but low profile telehealth. So a nurse went into the home and had an iPad, and then they could telehealth with Jory, or Dr. Fleischer, who was in the office. So she could still provide the care, but it was assisted with someone who was in the home. So I kind of like that as well. That would be another way to help bring it together, bring us a little bit closer together, instead of asking people to come all the way to our side.
Yeah, so Jory was on the series, and I wrote the article that was, I wrote the commentary before her article, and brought up the fact that as physicians, going to people's homes and seeing the living environment, right? Because we talk about, go out and buy this, salad ingredients and make this beautiful salad. But if the only food stores that are within 15, 20 miles of where these patients live are liquor stores, or, places that they get junk food, we have to figure out, and I think sometimes, like you said, meeting in the middle, us getting out and seeing where, the practicalities of having, our recommendations being carried out, and them maybe seeing that we're meeting them and trying to personalize maybe the care a little bit more, and maybe breaking down these cultural barriers a little bit more, so that we're not the white coat doctor in that expensive hospital with the parking fees that are $30 an hour or whatever in some of these places. I mean, you brought that up too, right? How expensive parking is. Even if we can provide care, the barriers to getting to some of the places are just, insurmountable from a financial perspective. So I think, I learned a lot from just this presentation, and also the one that you guys gave for the Davis Phinney. There's been a few other questions here. One is about the issue of culture and the cultural barriers. I mean, I think that, because when we think even about, why patients who are African-American don't report symptoms commensurate to what they're feeling, is it that they have a higher threshold to complain? Sometimes, somebody mentioned here that, sometimes people, there's actually been studies showing that physicians think that African Americans have a higher pain threshold, and hence give them less pain meds, and even African American babies or children are given less. It's not that we're having these implicit biases from older men or something that we think are have some drug addiction. It's literally, as a race, there's sort of systemic sort of biases that we have. But that's sort of an interesting thing, is, I wasn't too sure exactly why this coding of symptoms seems to be disparate to what disability is.
Yeah, I think it's interesting too, and it's kind of depends on what your perspective is. Because the other way to look at it was maybe white patients were over-reporting symptoms, which is like, so there's been this literature on knee replacements, and Blacks are less likely to get knee replacements than whites. So, I mean, as you can guess, disparities kind of crossed across all diseases, but when people have kind of critically looked at who's getting new knees, some have suggested that the white patients are getting over-treated with knee replacements. But I mean, some of it's just so subjective. I just don't know how, like, it's how you're experiencing your symptoms. I don't know how to say you're saying it's too much and you're saying it's too little. And I mean, I don't know why one group would report less symptoms than another group. It may just based on historically, maybe they've been like taught to under complain in some way because they don't get, they're supposed to like
there's stoicism,
not cause problems,
Yeah.
So yeah, I don't know. I don't know that. Yeah.
Yeah, it's very complex, and I think sometimes it sort of hurts your head a little bit to sort of put your head, figure out where to start. But I think, I really, we have 5 minutes left, Nabila, and I just wanted to tell you that, I've been a fan of your work for a long time. I think you came in as a fellow, and I was already, out here doing, our work here at West LA VA. But, I think you were kind of one of the only people who were on the top of the mountain yelling, like, please show us some attention. And I've been, thinking these things and trying to figure out how to, get people to start to pay attention, in some way. But I think you've really, brought the data forward. And I think you've proposed some very important, relatively, I think, easy, places to start at least the dialogue and start the changes. So I think there's been sort of some activism, and I saw someone here talking about the Avengers. The PD Avengers is a group of patient advocates that have started to think about these global issues, and we've had a number of them on the series. But really thinking about changing the dialogue and hoping to get Africa, every country in Africa access to levodopa, and even in our own backyards, there's, tremendous issues with even, getting patients referred to physical therapy or social work, to sort of see some of our patients in certain places. So I think, this is very important sort of, dialogue that we all have to have. So maybe just in the last few minutes, you could just tell us, what are your next steps in terms of what is the, I know you've been spending some time with Allison Willis, and we will repoke Allison, because Allison will teach us about the gender disparities, which are huge. And when you think about even the Venn diagrams, I've been struck by African-American women as a population, and the number of them that end up in, long-term care facilities compared to white men, for example. It's quite striking when you start to sort of add these differences together. So we will get Allison's input too, but maybe you could just teach us a little bit about sort of your next steps and what you think as a community of the listeners that are out here that are on our group, and many of them, as you see, are activists and asking all the right questions here, what they can do maybe as sort of the next steps as well.
Yeah, well, I mean, first of all, it's awesome to see so many people that are so interested in this, and I think it will take the village to really change it. So, I think everyone can, just in your day-to-day interactions with, bringing in other people with Parkinson's disease, making them feel comfortable, talking to them, just hearing about other people's experiences that might look different from you, that might have experienced something different from you. I think it'll help just start the dialogue and help people feel comfortable with accessing resources and understanding what else might be out there for Parkinson's disease. I think what I'm working on is working at the community level. Like I'm working this whole, it just started over the summer. It was a really great kind of grassroots movement that all the different movement disorder specialists across the different health systems in Philadelphia have kind of banded together to really get everyone working on this, not just one person. So all the providers are reaching out to our community referring doctors and strengthening the relationships with the ones that are more likely to refer minority patients, we're starting a research project to understand what some of the barriers are to coming into specialty care, and then the plan is to then take it the next step from the community, probably neurologists, to their referring primary care providers to try and meet people where they're at. So we've developed this consortium that is being run by one of our Parkinson's, they're a Parkinson's Foundation chapter, but they're called Parkinson Council. They're kind of organizing it so that we can all be on the same playing field and really advocating for patients. So it's been really exciting to be part of this effort.
That's amazing. It sounds like breaking down barriers, kind of reaching across the table and connecting, even if it's socially distanced, kind of as a joke. But, I think sort of getting everyone at the table. And I think getting the patient advocacy groups, all providers, not just movement disorder specialists that are MDs, anyone who could possibly meet and greet and touch that patient, it sounds like has to be at the table to figure out how to make this better, because there's just not enough of us, and most of us are concentrated in places. And I think even with telehealth, we can start to, access care for people at some degree, but your own data has shown that that's not going to be a solution to this. We really need to kind of break down some of these other barriers, and maybe, just even expanding support groups like the PMD Alliance, for example, to communities that may be, feeling like they would not belong, may not be able to, from a language perspective, arrive, maybe having some more programming to bring those folks in would possibly be ideas as well. But I think, lots of important information. So you, Nabila, have a lot of compliments here. Ken writes, my only issue with the PMD webinars is that I get so much valuable information that I'm pushed to read, learn, and study more, and I need 49 hours per day. I mean, that's kind of where I am. I'm just like, my mind's blown. Every time I get off of this, I oh, wow, there's all these issues with in Africa. Now they're here in Philadelphia, everywhere we turn, there's something to fix. But I think it's great that we have leaders like you, sort of starting the dialogues, continuing the dialogues, pushing sort of the envelope and trying to get in there, and anything that I can do to help, please let us know. And we'll have this video up and you can share it. And I will, hopefully we can link the great work that you guys are doing with the Davis Phinney Foundation as well, because I think that all foundations need to be covering this, and the more information, the better. So.
Well, thank you very much for having me. It was really a pleasure.
Thank you. Well, I'll hand it back to you, Andrea.
Yes, thank you. Well, yes, and Dr. Dahodwala, you put it on gallery view. We do a goodbye thank you wave so everyone can show their appreciation and share some smiles across the airwaves from we're physically distanced, but we're socially together and learning. And there's lots of bravos and smiles. So thank you, both of you. This was a fabulous hour of learning.
Thanks.
All right, have a good weekend.
Yeah, you too.
Bye.